to the next episode of our podcast, Gyan Pravah, meaning the flow of knowledge. And this powerful initiative is envisioned by our dynamic President Fogsi, Dr. Sunita Tandulwadkar, Madam, and it has taken a remarkable shape, instilling confidence in all of us as we embrace this platform. Now, Madam's vision is truly extraordinary, and as we step into the second month of this Gyan Pravah, the enthusiasm and dedication of everyone working under her leadership are clearly evident. And as the chairpersons of various committees, we are privileged to be the part of this monthly podcast, where we engage in insightful and enriching conversation with legendary personalities. And this initiative not only inspires us, but also allows us to learn from the wisdom and experiences of the distinguished figure each month. And I am deeply grateful for this incredible opportunity. And today I am your host, Dr. Pratibha Singh, Chairperson of International Academic Exchange Committee, Fogsi. And I am delighted to welcome you all as we discuss the groundbreaking ideas that are transforming the way we approach to childbirth with our legendary guest. But before that, it is a customary to introduce our President Fogsi, Dr. Sunita Madam, but she has requested that not to introduce her, but few words I will definitely tell about her, that without a doubt, she is one of the Fogsi's most valuable gems, poised to make history. And what I can say that she is a born leader who knows the way, goes the way, and shows the way, inspiring all of us. Because after all, great leadership is not just about leading, it is also about inspiring others to follow into the same footsteps. And we are really privileged, Madam. And now I'll request you, Madam, to please bless us, our podcast. Over to you, Madam.
Thank you, Pratibha. Pratibha, so nice of you to use such a kind word. But above all, I would like to congratulate you that you pulled out Dr. Professor Frank Lowen from his absolutely busy schedule. And I'm sure when you have such an academically established faculty, your podcast is going to be one of the best podcasts, I can say. Frank, this podcast is our Gyan Pravah, that is a little Sanskrit word that is flow of knowledge. We have 30 committee chairpersons, and since every month there are 30 days, every committee chairperson on that same particular day, every month does this podcast, which is sharp 8 to 8:45. First 5 to 10 minutes is a dialogue and welcoming the faculty. And then 30 to 40 minutes is a dedicated discussion. It may be on a academics of OBGYN, or it may be the spirituality, the philosopher, the politician, the film actors. Anything and everything is allowed as long as they are getting the personality which inspires all of us, which we learn with this dedicated 30 days. You all know that webinars were becoming too much. In last 4 years, every committee chairperson and every vice president had n number of webinars happening. And that's why my committee chairperson, I stopped webinars. I saw that the attendance to the webinar was thinning a lot, and only for the sake of doing some activity for the committee, they were doing it. So I changed completely the format. They have to give only 1 hour every month, apart from any other programs they are doing, which may be the physical CMAs, writing the book, co-authoring any chapters with anyone. There are so many activities we are doing otherwise. And Pratibha, I'm so thankful to you for having Frank. I still remember when I was there in the hall and the way his passion for delivering the breech vaginally. And I think at least 10% of the audience got motivated and probably are doing breech, not necessarily by cesarean, but by vaginal. So Frank, thank you so much for always blessing us, always being there for a Fogsi. I know We believe in Foxy that we do multitasking. For few to know that Frank is not only the European Society president, organizing a very big conference in June, where more than 1,000 faculty in 3 days he's getting in, but he's also taking over in Cape Town as a FIGO president. And India, we are promising around 2,000 Foxians will join to witness your inauguration or taking over ceremony. We all will come. We have started. Pratibha, being from the International Exchange Committee, she is taking a lead, and I know she has 600 plus followers in the country who just follow. She says, Bako chalo, people start moving there. So we will witness the grand inauguration and the FIGO following. Thank you.
So,
Sunita, thank you so much for your kind words, and I can't wait to see you soon.
So thank you once again, madam, and for reminding us your inspiration and vision. And today we are really honored to have with us Dr. Frank Lewin, a renowned expert in obstetrics, globally recognized for his pioneer research on alternating birthing positions and their impact on maternal and neonatal outcomes. He is the president-elect of FIGO, the world's most prestigious obs-gynae organization. And we are really eagerly looking forward for his official installation in October. And you just heard, sir, that Dr. Madam, Sunita Madam has already started planning to bring a large delegation from India for this momentous occasion. And we are really excited about this and opportunity to meet you in person. Now, sir is currently serves as a president of European Board and the College of Obstetric and Gynecology, that is EPCOG. And we all are looking forward for this EPCOG Congress in June in Frankfurt. And he's also the professor and head of obstetrics and fetal medicine at the University of Frankfurt, Germany. And additionally, he also holds the fellowship for esteemed institutions, including RCOG from UK, AGOS from USA, Foxy from India, RCPI from Ireland, and Congo from France. He is also the honorary member of Association of Obs and Gynae in several countries, including Ukraine and Israel. His extensive research focuses on molecular biochemistry and the cell biology, as well as the medical disorders including pregnancy, preeclampsia, and health syndrome. He has also made significant contributions to the management and the delivery of multiple pregnancies and breech birth. And notably, he is the initiator of the FIGO and WETOG initiative, that is Teach the Breech, which aims to advance education and practice in breech deliveries. So also beyond his clinical and academic contributions, he has dedicated almost 12 years to the board of German Society of Obs and Gynae and continues to serve as a voluntarily as chairman of board for both the German Foundation for Women's Health and Pro Familia Hessen. So today we have the privilege of exploring how breaking traditional norms in birthing position can lead to a better birth outcome. And I'm so happy, sir, that in spite of being so busy, you are here with us. And it's an absolute honor to welcome you and request you to please share a few words of wisdom with us. Over to you, sir.
Pravita, thank you so much. That was such a kind introduction. It was hard for me to recognize myself with what all you have just delivered. So, Sunita, it is a fantastic idea to start that format, to get in, not just only in contact, but to discuss in a conversation what might change our view on what we are doing day and night in our profession. And this is, Pravita, I mean, I love the idea when you first asked me to discuss that the normal birth, at least, we are discussing what went wrong in evolution that giving birth to a child is a burden for a woman. And thinking about it means immediately, why is in evolution, and I mean there is a sense of evolution, why is evolution helping to reduce complication, to make something easier, but not in labor? And what is interfering here? And is it really true that evolution was not able to at least, well, make a woman able to deliver just one child without massive complications? And we have to realize all these massive complications, not just only postpartum hemorrhage. Actually, we are realizing that just within one generation in Europe, you have a 50 to 80% increase of women not delivering on the estimated date, needing induction of labor. So the likelihood to have and to need an induction of labor for post-term deliveries increased by more than 50% in Europe. How come? I mean, that means immediately something's wrong here. I don't know the numbers in India, but I believe it might be nearly the same, right?
Absolutely, absolutely, Frank. I understand. And I'm sure this podcast is going to be very, very interesting. Only one addition, Pratibha, while discussing with Frank sometimes 2 years ago, I also came to know he had interest and worked in a stem cells.
Yes.
Because I wanted to have one-to-one dialogue with you on the stem cells, the regenerative medicine, which is a very close topic to my heart. But
I would love to.
Some other time we may take one podcast on that, because whichever month 31st is there, I come in the picture and I take the podcast, but it's mainly on a spiritual topic. But some other time we will be definitely, Frank. And our protocol says now I leave and Pratibha will take your beautiful dialogue with you and will enjoy from another link. Thank you.
Thank you, madam. Thank you.
Thank you so much. See you soon.
See you soon.
Okay. So, sir, welcome once again, sir. And you have already started your conversation. So, but first of all, I was just want to know that actually not even me, everybody is inquisitive that why there was this need of to rethink about this traditional birthing position. Why there was the need?
Yeah, that is so important. I mean, we have to rethink that. And everything starts, I think, in science, and especially in our profession, that we have to define what is normal, what is pathological, and if there is something pathological, is that an indication for an intervention? Discussing intervention not just only means that we decide to do a cesarean or not, or an operative vaginal delivery or not. We have to recognize that something's going on here. If you just compare the last, let's say, one generation, 30 years. Within 30 years, the numbers for maternal laceration, perineal laceration, increased. And today, we have to recognize in our surveys, I think you have same numbers in India, that more than 80% of all women have a laceration of primigravids when they give birth to a child. What went wrong here? I mean, if evolution is responsible for the fact that there is an ongoing progress to reduce complications, how come that after billions of deliveries of human beings, the complication rate for perineal laceration is increasing? Second, more and more women need support in second stage, not just only with hormone replacement with oxytocin, but also with procedures like fundal pressure or with kiwi or with vacuum or with forceps. And in our profession for a very long time, we just compared our numbers. We tried to develop better instruments in these cases, but we never thought about the fact what happened within one generation. Why do women have so much more complications today compared to their mothers and grandmothers? I mean, genetically, that is completely the same. There is no difference. So what happened here? And the easy answer is we have to reflect everything what we are doing. One thing is the birth position. So what is happening in labor? If a woman, if it just related to the birth position or our behavior with the women in second stage. Everyone knows that from 20 weeks ongoing, the maternal pelvis becomes more and more mobile. So the pelvic bones are not any longer fixed like in an unpregnant woman or in men, but it is an increasing mobilization. The answer in the textbooks is, let's say, a little bit uninspiring, because there is just the saying, because human neonates are so huge, the maternal pelvis has to adopt in labor, otherwise the baby cannot be delivered. If that would be the explanation, I would believe that women on Earth would have a wider pelvis. And I mean, you know, evolution always works with attractiveness. So men would love women with huge pelvis because that at least helps to deliver their children. That is how it works in evolution. But that is crazy. That is wrong. So women are perfect today to deliver their children. So why is the pelvis of a woman in pregnancy becoming more and more mobile? The answer is easy. I mean, you know the inlet and the outlet of the pelvis. Because of the structure, the fetal head has to turn 90 degrees, transverse in, and then after 90 degrees to be delivered, there has to be a rotation. And that the mobilization of the pelvis is supporting the rotation of the fetus. Because if a woman is mobile in labor and not any longer lying in a bed, then, and I can show it, I don't need a presentation for that. Imagine my both hands here would now be the pelvic bones.
Yes.
If you're standing on your right leg, this is fixed.
Yeah.
And this is mobile.
Wow.
So the baby's head can push to that direction. Then the woman walks with the next step, and this pelvic bone is now fixed, and this is mobile, and it turns back, descending. And if there is a next contraction and the woman leans forward, the back of the baby turns around. So mobilization is the first key issue, what we have to change. If a woman is lying on the back, if she's lying with her mobile pelvis, she's lying with her whole weight and with the weight of the baby, she's lying on the os sacrum. So that is if all the weight is here on the os sacrum, then you have a descending of the pelvis. So you have a decrease of the inlet. Second, because these bones are mobile, they move to that direction. So at least it is not easy for the baby to come in. And if you look to the numbers in your perinatal surveys, I strongly believe it's the same as we have to recognize in Europe. We have an increasing number for secondary cesareans because babies not any longer pass into the maternal pelvis.
Yes.
You can see that in all the perineal surveys. Is the answer that women have a decrease in the size of their pelvis? No. But if they are lying on the back, then because of the mobilization of the pelvis, the size is decreasing, and therefore the baby needs much more pressure to enter the maternal pelvis. So, second, if the baby rotated fully, again, think about the mobilized pelvis bones. If you are on your knees, then the legs are here on the pelvic bones. Then you have an opening, an additional opening of the pelvis, and also the osacrum moves to that direction, so it becomes wider. Third, did you ever try? So what if you contract your abdominal muscles when you are sitting? You immediately stop that, because there could be a side effect you don't want to have in that situation now. So I wouldn't start with contracting my muscles here, otherwise I have to leave the conference immediately. You know what I mean? If you are lying on your back and you contract your muscles, there is no more pressure on your pelvic floor. You can try that out. If you are in a gym and you just do exercise for abdominal muscles, if you are lying on the ground, there is no pressure on the pelvic floor. If you are sitting and you contract your muscles, there is a massive, you feel that immediately. If you try it out now, sitting here in front of the screen, and you just contract your muscles, your abdominal muscles, you immediately have a massive pressure on your pelvic floor. So lying on the back, you cannot contract with contraction of your abdominal muscles. You cannot put pressure on the baby to be delivered. We believe that. We ask the women, take a deep breath, contract your muscles, push your baby down. It's not working. So we have to rethink. And rethinking means, let us start with new studies. And that is what we have done in the last 20 years. So we randomized women lying on the back and in upright position. And what we compared was the duration of second stage. We compared also the likelihood to have a vaginal operative delivery. We compared the numbers of secondary cesareans in second stage. And what we also found out, and that was a surprise 10 years ago, what we also found out is a massive reduction of lacerations of the maternal perineum. So we have a reduction, that massive reduction is extreme. It is decreased in a premigravid from 80% to 10%. And laceration grade 3 or 4 are absolutely rare if the woman is in upright position. And the explanation is so easy. If a woman is lying on her back, this is a fetal head, this is a maternal perineum, here is the symphysis. In that direction, if she's lying on the back, the baby, the uterus will push out the baby. So first, the baby's head has to pass the perineum, and then the head can be delivered. If you turn the woman around, and now the baby's lying in that direction because she is sitting on her knees, so she's on her knees. This is a fetal head, this is a perineum. So then you see the direction of labor is down there, so there is nearly no pressure on the perineum. You have a slightly increase of lacerations of the labia minora, but a massive reduction in perineal laceration. It is just depending on the birth position of the mother. And you have seen the videos. I mean, this talk is not about breech, but you have seen it in the videos. Same with breech deliveries. You even don't have to touch a baby to deliver the whole child if she is in upright. If she is in a lying position, in a supine position for labor, then definitely you have to do the maneuver of Bracht, and in most cases also maneuvers to deliver the arms, like Löfset maneuver or classical maneuver or whatever you want to do there. So the birth position seems to have a massive impact. So my answer is, as an introduction to our conversation, we have evidence that the birth position has a massive impact on maternal complication rates in second stage and labor.
Yes, definitely, sir. You have explained everything. That what is the physiological benefit of this alternate position, and also how safe it is, whether it is for the continuation of the pregnancy or for the lacerations, which happens normally when the patient delivers in a supine position, and how the pelvis rotate. That is very important, which we should be understanding. And I think the gravity also plays a great role, because
Absolutely.
that it comes in that aligned with that, and then the delivery becomes very easy. So can you, sir, can you tell me what are the different alternative positions, like apart from knee chest position, any other positions are also there where this will help, or it is only the knee chest position is the best position?
Yeah, that is if we just actually observe cephalic presentation of the baby, then these women in our unit, in our studies, those who are in the arm of
I want to interrupt one. Like in our Indian scenario, people used to say you sit and do the squatting position. That is also will help. So do you
Yeah.
think, yeah, that type.
Yeah, absolutely right. That is absolutely right. You can sit or you can be on your knees, but you just do that only when you feel that you now definitely have the pressure to deliver your child. So when it is fully rotated, it is +4, then the woman goes on her knees or is in a sitting position. Before that, they are only moving around. They are walking, they are standing in front of the bed, they are not lying in the bed, they are not on the left side, right side, supine position. No, they are upright, they are walking around in second stage. So we really and women are very supportive. I mean, it is a myth that women want to lie in bed for labor. That is wrong. You will see that. If you start with a study, and you just start with a study asking women which position do you prefer, you will see that more than 90% immediately are very thankful that they can stand up, because it's painful lying in a bed in labor in second stage. And if they get up, you have a massive reduction of pain. So it seems so that we are a bad factor in labor with counseling women to go to bed to deliver their children. It seems so that other positions are easier. You're absolutely right. What you should avoid is the supine position.
Okay.
But also lying on left or right side is decreasing the size of the pelvis. And if you want to increase it, because the pelvis is mobile now, you just have to ask the women to sit or to be on their knees. And they don't have to be on the knees for hours. It is just for pushing the baby out.
Definitely, sir. So definitely, sir, what you have told is really correct. But even after watching your videos, I have also tried one case, because normally this is a very unusual position. And when we tell our patients, they are not very convinced. I mean, we have to change their mindset also. So one of my patients, although unfortunately I could not take the video because the patient did not allow that. But it was really very, I mean, when we started, even my team and all the staff was a little bit scared. Actually, they wanted to know that whether it will be possible or not. But we could do it properly, and there was a very little tear I could get with that.
Yeah.
So how to avoid those tears? Like you said that there is no possibility of any, because we could not do any support system. I mean, we did not support the perineum and all those. But still, there was a little tear in that. So, do you think that is okay, or we can avoid it also?
Well, first of all, I think what we observe is that at least laceration grade 1 don't need any surgery. So you can compare that. Additionally, there are a lot of discussions And I understand that if you're a young doctor, then you want to train yourself and you want to close it and you have the feeling that you have to do it for aesthetic reasons. But if you compare laceration grade 1 and the one group is surgery, the other is not, the result is the same after 2 months. It's completely the same. So maybe you can do it, you can do surgery, but so lacerations grade 1 seem to be related to labor, because nature in evolution was able to repair this without any other help. Laceration 2, 3, and 4 are real complications. And there is no doubt that without proper surgery, you have massive complication in the rest of your life. There is no doubt.
Yeah.
So the question is, can we reduce laceration 2, 3, 4? And yes, if she is in upright position, if the baby's head is here and there is a perineum, there is nearly no pressure. So if the woman is lying in a supine position, then the midwife or the doctor has to hold the perineum to reduce the lacerations 2, 3, 4. But if you turn around, nothing is needed here. And you can see sometimes if you have women who had a laceration in a previous delivery with a suture here, then you can put your fingers on the perineum and just hold it a little bit with your fingers. You don't need that. There is no other support needed to reduce the rate. Do you want me to show one of these breech deliveries in upright positions to see what's happening on the perineum?
Yes, sir. It is.
So then I just push share my screen.
Yeah,
Here
yes.
it is. So I think now you can see it.
Yes, sir. Yes, sir. We can see.
Fantastisch. Super.
Komm, genau. Druck mal.
Sehr gut.
Sehr schön.
Ja,
komm.
weiter. Schieb ruhig ein bisschen noch weiter. Schieb noch ein bisschen
Genau, ein
weiter.
bisschen mehr.
Fantastisch.
Sehr gut.
So here you see the perineum
Yes, sir.
and the anus.
Yeah.
And the anus is white, but it is red. There is no white structure here. Same with the perineum. So the baby is fully rotated and there is massive pressure now from the posterior hip here on the perineum. But as you can see here in the video, it is completely red. There is a good perfusion. There is no pressure actually on this perineum. Although the baby is just passing through. And let us wait for the next contraction, then you will immediately see what's happening here. So you will see on the baby's hip, that will become white because of the huge pressure, but the perineum is still very good perfused without anything what's happening here. It is just a structure in labor, and there is no complication. So we are waiting for the next contraction. And that is a perfect video to demonstrate what it means just if you turn the women around. So we will see now when she has a next contraction. You know the story with the green gloves from her midwife colleague. Now she has, and you remove these, and now you can see it. You can see it. Now you see it is white. The baby becomes white here because of the pressure. The perineum not.
Yes.
It is well perfused. There is no pressure. There is no laceration. There is nothing. Also, that breech baby is just delivering legs, arms, and then later the head, and it is out. And there is
Wonderful.
zero laceration.
Yes.
I mean, that is a
Wonderful.
huge difference.
Yeah.
And you can see that perfectly in the
Perfect.
video.
Perfect, sir. This is
Yeah.
perfect. I think our viewers will really get insight from this. And sir, but one candid question: did you had any face any any resistance for this position?
That was a massive surprise. I mean, you can explain that because of our structures in our hospitals. So we have doctors and midwives together in labor wards. And the midwives usually are responsible for the women. And if there is any pathology, then you have to call the doctor who is on call, who is in the
Yes.
unit, who is sitting with the midwives in the labor ward. But then the responsibility is changing. So it was absolutely easy for me to convince my colleagues, the doctors. So they were inspired and they said, oh, let us see that. And to do it in a study is always helpful because then you immediately have them on board and they are understanding, okay, we want to reduce lacerations, we want to reduce complications, we want to increase the number of vaginal deliveries, and so on and so on. So they know what they have to observe. The biggest resistance was from the midwives.
Midwives, yeah, definitely.
Because they were trained delivering women in supine position.
Yes, yes.
So it changed. And so first I wanted to convince them that it is good for the mother to be, it is not harmful for the baby, it is very supportive. But that didn't help. So then I told them, okay, we want to introduce you in the studies and we want to integrate you. So we need your help. Please help us supporting the women. This is your responsibility here. And we will then every month we discuss the results of the last month with the deliveries in both arms. And then you increase their interest.
Yes.
And today in my unit, I have 42 midwives. Only 2 midwives still, sometimes in the night, turn the women to supine position. And all the rest of the 40 in the morning are telling us, why did you do that? It is harmful. It is not good for the women. So now they are convinced, but it took me years. So it is not just easy to say, okay, now we change. And if you tell people, let us do a very simple study on this. Let us develop a protocol, one arm, the other arm, what do we compare? Let's see how that is supporting women. Then immediately it is changing. And additionally, we introduced the concept why the women has to move around, walk around, how her partner could help her, and how we deliver. We introduced that to women in 30 weeks. So we invite them to discuss natural.
We have to include them with us, then only I think they are going to be convinced. And what about the patients, sir? Like when you tell them that this will be the way we are going to deliver you. So do you face any problem with them, or you are, just counseling them since they are in antenatal period?
So if you introduce the impact of maternal birth position in labor in 30 weeks and not just in labor, but 10 weeks earlier, then they understand. And there is also something what is important for us as gynecologists. That is our profession. We were taught since we started in our profession. So for us, examining in examinations, gynecological examinations, to have the women lying in a supine position, spread legs, that is normal for us because we do all our diagnostic procedures if the woman is in that position. So women accept to be in that position if they go to a gynecologist. But it is never comfortable. That is not new. It is never comfortable to be in that position. And if you then tell women, you don't have to be in that position. If you are sitting or on your knees, no one will observe your vagina because there is nothing to be observed when you deliver a child. You will see the baby's head or the baby's hips when it is a breech baby, when it is delivered. There is nothing you have to observe. They feel better with it. So they get, and so introducing them that this position is not needed. Second, you can, if you want to support your delivery of your baby, contraction in upright position is helpful, but a contraction of your abdominal muscles in a supine position is definitely not working. So then they understand, okay, I want to support the delivery of my child. I want to be active in that situation. They are happy about it, but we have to introduce the concept.
Yeah,
And
before.
then they definitely want to. You will see that they are so engaged. They understand, okay, now I know what I have to do, and they explained it to me, and the midwives are on board, and everyone is in the concept. So that works very well. And then you will see you have a massive reduction of complication. So we have the lowest perineal laceration rate in whole Germany. In whole Germany, if you compare it in our perineal surveys, my unit has by far highly significant less lacerations compared to all other units. And the answer is because today all cephalic and breech babies are delivered in upright position in my unit. But it took us years. You're right.
Yes, definitely. And sir, now one more question that is there any other situation where these alternative position are not recommended?
Yeah, sure. That is if you definitely have to do operative vaginal deliveries. So forceps or vacuum is not possible in upright position. I tried it. So we really tried also to develop instruments or to understand whether that is also support. It's not. So unfortunately, I have to say, if there is an indication for an operative vaginal delivery, then the woman has to turn around to supine position to do it fast, easy, and with making sure that you don't induce any other complications.
Yes, sir. So there are few, that you have to take care of it. And if you are expecting that you have to put some instrumental delivery, if you have to do, I think you have to turn her to the supine position. That is important.
Yes.
So, sir, do you think that there should be some change? There will be a change in the hospital policies and which you can foresee, like advocating such type of birthing positions? Yeah,
absolutely. I think coming back to my introduction, my strong belief is that we should, from time to time, we should sit back.
Yes.
And just observe what we are doing and how we are counseling on what we are. We also have to recalculate, is our belief related to the results we want to observe? So my strong belief, and I think that is in all fields of medicine, that is in all fields of gynecology and obstetrics, is also when it just comes to the normal vaginal delivery of a singleton baby at term. So when we observe all these high numbers of complications and we are discussing again and again how to improve this, I think it is fair to say, okay, are we doing something wrong here? What is our role here in that situation? And therefore, I would love to develop a program with you in Fogsi.
Yes.
To at least start with a few hospitals in India, to introduce a randomized trial to convince people. It is really to convince the staff, the midwives, the doctors, to introduce it as we have done 10 years ago. And it would be a fantastic publication. You have so high numbers. You have so much engaged colleagues there. I'm very thankful that you invite me again and again to India, and I see them, and I can see how much engaged your colleagues are in India. So why don't we just start something like these randomized trials in your hospitals? And I would love to join you there and to discuss it. And maybe when we have the next Fogsi conference, we could sit together for an hour and develop something. And then these hospitals would be ready to join us here, and you will see then in your surveys you have a massive reduction of complications.
Yes, sir, definitely. Nowadays what we see, there is such an increased rate of cesarean sections. I think that reduction will be there definitely if we change this if we change our concept, that is important. That change is very important.
Yeah.
But sir, I just want to say that it is an unusual position. And even when you have started your career and when you have started advocating this, so can you share us some any memorable birth experience that has reinforced you to believe that this alternative birthing position is good? And since then you have started this. I just want to know how you started advocating this position.
Yeah, really the beginning. Now I'm not talking about breech. Now I'm talking about cephalic presentation at term. So that was very much influenced by recognizing the increasing need of fundal pressure, the increasing numbers of operative vaginal deliveries all over Germany and then all over Europe. And also the very high laceration rates. So accepting that 80% of all primogravids have a laceration in labor, knowing that number, we immediately have to ask ourselves, okay, what's going wrong here? That cannot be the result of hundreds of thousands of years of evolution. That can't be. Usually eating is easy, drinking is easy, and giving birth should be easy. So, and additionally, today, I don't know the birth rate in India, but in Germany, women just have 1.4 overall the rate, 1.4 babies per woman in Germany. Maybe you have 4 or 3. Yeah, something like that. So we have just 1.4. But if just 2 generations ago, their grandmothers delivered 8 babies. Only 3 survived or 4, but they delivered 8 babies. So there seems to be a need in evolution to make sure that the perineum of a woman after giving birth is healthy. Otherwise, you cannot deliver 8 children. How could that be? You would avoid everything to become pregnant again if you are destroyed in the vagina, in the vulva, in the perineum. So there was something wrong, and I thought, okay, what could lead to these high rates? And first I thought, okay, maybe it is the structure of the tissue, maybe something's there, behavior, no sports, or whatever is the reason. But then I understood, okay, but what if the birth position is the problem? And then we started, and we recognized it also in breech deliveries, and then we compared the breech experience with cephalic experience. And today the concept is completely clear. And you wouldn't find, I couldn't do any more randomized studies here in my region, because every woman in Germany, and especially here in my state, home state, and in Frankfurt, no woman would lie on the back. They would say, "Oh, are you crazy? No. I don't want to have a laceration, and I want to help a little bit. I want to have the ability to put pressure on my pelvic floor when I have a contraction and so on." So today they understood completely the concept, but it took years on the one side, and the reason was that I found that the laceration rates are unacceptable high.
Definitely, sir. You continued with your passion, so that is really wonderful. And it is really, that we must follow that, and it is really going to help our pregnant patients. Now, just one personal question, sir. Beyond medicine, do you have any passion or any hobbies apart from medicine?
Yeah, that is sports. I love football.
Okay, very nice. Very nice, sir.
Yeah.
So you must be playing also, sir? So,
yeah, I'm playing football, and also I was once I had a contract in a first league team when I was young. But now I'm here since more than 20 years. I'm in Frankfurt, and therefore, yes, sure, I'm behind the team, our team here in Frankfurt.
But sir, you look fit, and it doesn't look that. You have that sports personality, so you can go back for that. So definitely, sir, you should continue with your passion, your hobbies also. That is important. And any message you want to give to our viewers, our doctors who are watching? Few midwives are also watching because I have asked people to watch this podcast because this is very important. So, do you want to give some message to them regarding your this change in the birthing position?
Yeah, there is one message that is my strong belief. Never accept something what is increasing complications. Rethink what might be the reason for it and change it.
Yeah,
And never stop believing that evolution is giving us the opportunity to reduce complications.
thank you, sir. And anything else, sir? Sir, what do you think in India? How can we proceed with? Like you have said that we can start doing some projects together, but how it has to be started, sir? You must encourage us, and you should give us some guidelines about according for that.
Yeah,
So,
but that would be beautiful. So maybe I mean you are one of the shining stars in Foxy, and we know each other since such a long time. And I know that you are also inspiring.
I keep bothering you always.
No, you are. No. Really, Pratibha, you are. So why don't we plan? I mean, we will have the next Foxy conference in January, right?
Yes, January in Delhi this time.
So we have time enough until we meet in Delhi. And
Yeah.
why don't we sit together with these Zoom meetings, or when I'm coming to India in the next month?
We'll meet twice in Frankfurt and then in Cape Town also. But that time you
Yeah.
will be busy, I know.
So
But
then we could sit together and
Yeah.
we deliver a protocol, and then you invite hospitals in India, and we really start it. And
Yeah.
it is all the different structures. What does it mean for the women? What does it mean for the staff? How can we reduce laceration rates? So it is one huge randomized protocol with very different focus parts in the study. I would love to help you if you want to deliver that. And I think if you have that study in India, the whole world will recognize what you're doing.
Definitely, sir. Thank you so much, sir. And last question, which Dr. Sunita Madam has told about your stem cell research. So
Yeah.
something you want to tell about that?
Yeah, the stem cell thing, that is completely different. That is a part, I'm on the one side, I'm the director of the clinical part. And you know that from Breach and all these things, and also what we are discussing right now. The other thing is that in my first life before I became doctor, I studied chemistry. And therefore, my second love in the field is my lab, my molecular biology lab.
Okay.
And we were interested in why is obesity leading to heart complication, to vascular complication in women, to increasing cancer rates. So what is behind the obesity thing? And these are ongoing studies, but we published a lot. What we found out is that our stem cells, the stem cells we have in our body for repairment, if something's going wrong, if I have a heart attack, then my body sends stem cells to my heart to replace the muscular cells in my heart, and to make sure that the cytotoxins which are produced there are in a stable and healthy situation. So stem cells have a lot of things to do in our body. And now the bad message is, if you are obese, then these stem cells are not any longer working. So they don't find the place. There is structural change with the cilia, and also their production is reduced. So they can't fulfill their duties compared to people with normal weight, without obesity. So to understand these mechanisms is extremely important if it comes to how to prevent cardiovascular or oncological situations, and even preeclampsia in obese, in obese women, preeclampsia rates are increased. And what we found out, it is not only the stem cell of the mother what is impaired by the maternal obesity, but also the fetal stem cells are impaired. And these stem cells, which are responsible for the dilation of the maternal spiral arteries, in the first trimester, these extravillous trophoblast cells try to find the spiral arteries in the maternal uterus to dilate it, to increase the perfusion. Also, these stem cells are impaired and don't find the maternal vessels, and that is increasing the preeclampsia rate. So that is unbelievably interesting. That is the other part. That is what I love in my job.
Definitely, sir. And we need another podcast for this. Definitely,
Sure.
we would love to learn from you.
Yeah.
Okay. So, sir, now I think we should wind off because now we are coming to the end of our podcast. And so thank you so much, sir, for sharing such invaluable insights with us and the concept. And if it is adopted, could lead to a safer and more effective deliveries. Because breech deliveries often result in elective cesarean sections, and it is essential to promote such alternating birthing positions, particularly this knee-chest position. And for this, I would like to express my gratitude to sir for emphasizing and sharing such valuable knowledge with us. And I'm really eager to participate in this trial because your work contributes and continues to inspire us positive changes in the maternal care. And I also want to extend my heartfelt thanks to our Fogsi President, Dr. Sunita Tandulwadkar, Madam, for providing this wonderful opportunity. And to our listeners, if you found this discussion enlightening, please share it with your expectant parents and healthcare professionals. Because once again, my sincere thanks to everyone who contributed to this podcast. Until next time, let's keep striving for the better tomorrow for our pregnant females. So thank you so much, and thank you and good night. Thank you so much, sir, for sparing your valuable time. Thank you.
Pratima, thank you so much for inviting me. I'm very much looking forward to
Thank
meet
you.
you as soon as
Yes,
possible.
sir.
Thank you
Yes,
so
sir.
much.
So I'll be coming to Frankfurt for your APCOG conference.
Yeah,
And I'll be visiting your hospital also at that time.
yes. So then I see you soon. Great.
Yes, sir. June will be coming. Okay. Thank you.
Thank you so much. Bye-bye.